So thanks, Dr. Natarajan, for asking me to speak in this. Very briefly, that I will go in this session about difficult cases basically. So what I have is a 27 gauge vitrectomy in keratoprosthesis. So yeah, so we have nowadays a lot of people undergoing keratoprosthesis for various indications. Most important is the ocular surface problems. Now, whenever you have ocular surface problem, therefore us as retina surgeons, now cornea people have a lot of work to do, but for us retina surgeons, whenever you have to do vitrectomy, the sclera, the condition of the sclera and conjunctiva and wound closure becomes very important. So you can't have a 20 gauge like in the first case, osteoodontoprosthesis, lids are closed, you don't know where to make the incision, forget about suturing the incision once you make. So if you have any leak, even if you put a 25, in these cases you can have leakage and you won't even know about it. And the other problem is that if you have like the second case bottom here left, you have such a small palpebral area, tarsorrhaphy has been done after keratoprosthesis. It's just so much narrow space, you just can't put, I forget about 20 gauge or even 23, even 25 you have only 3 clock hours where you can put 3 instruments, 1 infusion, 1 light pipe and 1 other cutter. You have just 3 or 4 clock hours because of the tarsorrhaphy, and these are kind of sometimes permanent tarsorrhaphy. So if you have such a limited area and the surface is very bad, so you have a lot of difficult situation of accommodating 3 cannulas there or 3 sclerotomies there, and also the surface, if it's really bad and you have to suture the sclerotomy, then you are in for big trouble because it doesn't close very easily. So I'll just show you one very brief video about so this patient had a Boston Capro type 1 and we used 27, all 27 gauge are valved cannulas by design, you don't have a non-valved. That's one thing, but the other thing I have found is the infusion rate is also slow in 27 gauge. Sometimes you have to use 650 vacuum, 500 vacuum, but the flow of the infusion in young patients who are thick vitreous, that is impaired. So this is a very young patient, about a 19-year-old who had xeroderma pigmentosum, had Ahmed glaucoma valve. So there is a tube here, as you can see, AGV tube protruding in there, that has been blocked by the vitreous. Now vitreous has come into the AGV. So what we are doing is we are doing a membranectomy along with removing the vitreous from the Ahmed glaucoma valve. So these are some of the indications where ocular surface, limited access to the eye, all these conditions are there. I think 27 gauge is a very valuable tool. Other than the routine cases of ERM macular hole and macular surgeries, I think they have a very big role. Now, some of us may not have a huge practice of this kind of patients coming to us, but wherever there is such difficulty of either ocular surface or limited access, I think this is a very important tool in our cases. So this was just a very small presentation that I had, and if you have any further questions, I'll feel free to ask. Thank you.